Hello everyone, and today we will be learning cervix and regional lymph nodes, normal and pathological anatomy on imaging. So cervix is a fibromuscular organ, approximately 3 cross 3 centimeters in size, and it is divided into supravaginal and vaginal portion. The supravaginal portion, also known as the endocervix, faces the bladder and rectum, and it is covered by the peritoneal surface, whereas the vaginal part, which is the ectocervix, is separated from the vagina by vaginal fornices. Cervix is supplied mainly by uterine artery, which is arising from the internal iliac artery, and this uterine artery has got three segments: parietal, parametrial, and mesometrial segments. And it is the parametrial segment which is crossed by the ureter, and this is roughly located at around 2 centimeters from the level of isthmus, and which corresponds to the traditional point 8 definition. Cervix is supported by several ligaments. Of these, there are three important are transverse cardinal ligament, the uterosacral ligament, and the pubocervical ligament. On a normal CT scan of the pelvis, it is difficult to identify a normal uterosacral ligament. However, it can be identified if there is a pathological involvement in the form of a thickening. It is important to also appreciate that the uterosacral ligament runs outside the mesorectal fascia boundary, and in a case where there is an overt involvement of the uterosacral ligament, in a very advanced case, we need to include the entire mesorectum in order to incorporate the uterosacral ligament into our volume. The superior boundary of the parametrium is defined by the top of fallopian tube or the broad ligament. Inferiorly, it is defined by the urogenital diaphragm. Anteriorly, it is defined by the posterior wall of the bladder or the posterior edge of the external iliac vessels. Laterally, in some of these guidelines, as these images has been taken from there, the parametrial lateral limit has been defined till the obturator internus muscle. However, important point to stress here is you can identify this homogeneously smooth area, which is nothing but a fat containing area containing the vessels and the lymphatics, and this is not a part of the parametrial contour. So in this case, now if we have to redefine the parametrium in this section, this will be our parametrial cut and this lateral part would be excluded. Out of the several imaging modalities, CT, MRI, USG, and PET-CT, MRI is the best modality for local evaluation of the disease. And out of all the sequences, for us, the most important is the T2 weighted sequence. For nodal and distant metastasis, PET-CT, however, is superior in terms of sensitivity to CT and MRI. So first coming to transabdominal ultrasonography. So in this axial view, we can see the central uterus, and then there is a central hyperechogenicity, which is because of the endometrial canal. More well appreciated in the longitudinal view of the ultrasound. Here you can appreciate the interface between the uterus and the bladder, a central hyperechogenicity, which is going down as well and continuing as the central hyperechogenicity of the cervical canal. And rest of the uterus has got a almost kind of homogeneous intensity. Transrectal ultrasonography gives a much more clearer picture, and it may be of very important significance to understand the anatomy because it may be used during real-time imaging for the brachytherapy application, and also to quantify the extent of the disease, maybe after external beam radiotherapy. So on the transrectal ultrasonography, this is the probe in the rectum. So this is the probe part. This is the rectal wall, which is lying just adjacent to the probe. This is a pear-shaped uterus that you can see. This is the fundus part of the uterus. This is the central echogenicity, as we discussed, of the endometrium, and this is the echogenicity in the cervical canal. And similar findings appreciated on the axial view as well. Now, if we acquire a non-contrast CT scan of the pelvis, it is very difficult to identify several of the structures. However, with a contrast-enhanced CT scan, some things can be defined. It is important to understand that the peripheral myometrium shows enhancement takes up the contrast, whereas the central endometrial part, would generally be appreciated as a triangular or a ovoid low density signal. Uh, Again, to emphasize that the endometrium and the cervical stroma will have a lower density as compared to the myometrium, which will show an enhancement. In the sagittal section, you can appreciate the myometrium showing an enhancement, the endometrium showing a low signal intensity, and the cervix part showing a lower signal intensity as compared to the myometrium. So this thing is very important to remember, and this will be helpful for us when we will be discussing later on CT planning on CT-based image-guided adaptive brachytherapy. On a contrast image, we can also appreciate peripheral enhancement, which is nothing but the paracervical plexus, the blood vessels in the paracervical area, which is taking up the contrast. And parametrial fat stranding, although can be seen on a contrast enhanced CT scan, it's difficult to delineate or demarcate the extent of the parametrial involvement on CT scan, and CT scan is a poor modality for delineation of the parametrial involvement. Now, when in the presence of a cervical cancer, the cervix cancer, the tumor itself, will generally be either iso-intense or through a low signal intensity as compared to the normal cervix. So it would appear in this case as a hyper-enhancing myometrial, the central endometrial component. The cervix cancer itself is showing almost an iso-intense density as compared to the normal cervix. We can appreciate it's very difficult to understand the extension of the disease, the gross tumor volume in this case, the upper body or the uterine extension of the disease, and this is a limitation of the CT scan. CT scan can although give us some additional informations like maybe a gross perimetrial invasion, a hydronephrosis, or para-aortic lymph nodes. More important for us is to understand the MRI radiological anatomy. So the most important sequence for us is T2 weighted images, and we can appreciate a central hyperintensity, and this is nothing but the endometrial cavity with the fluid secretions and the glands inside it, which is showing a hyperintense signal. Adjacent to this, there is a low signal intensity of a inner myometrial junctional zone, and there is an intermediate signal intensity of the outer myometrium. Outside this, there is a low signal intensity again of the peritoneal layer or the serosal layer of this thing. So this is very important to understand the hyperintense signal of the endometrium, junctional zone low signal intensity, intermediate signal intensity of myometrium, and then the peritoneal layer. Now understanding the anatomy of the cervix. Again, there would be a central hyperintensity because of the endocervical mucus and the mucosal glands. Adjacent to this, the cervical stroma will have a low signal intensity, which is very important to understand. And after this, there will be a smooth muscle which will show intermediate signal intensity. You can also appreciate the fornices, the anterior and the posterior fornices, the internal, external os, and approximately 3 cross 3 centimeter dimension of the normal appearing cervix. Vagina is difficult to delineate on MRI. However, there would be a central hyperintensity in the vagina, mainly because of the vaginal secretions which are present there, and it generally appears as a H-shaped structure on MRI. And there would be a peripheral low signal intensity from the vaginal smooth muscle. So in cases where the vagina is not involved, this low signal intensity of the smooth muscles would be preserved, which will be seen in subsequent slides. So this is a case of cervical cancer, and the normal cervical cancer itself will appear as a hyper intense signal. So it is important to understand that the low intensity cervical stroma in this case has been pushed out. This is a cervix cancer hyperintensity signal, and this is important to remember. Even after the external beam radiotherapy, when we use MRI compatible applicators, acquire MRI images, the residual disease in the cervix will appear hyper intense as it is appearing here. This is the normal isthmus area with a normal appearing low signal intensity of the cervix, the intermediate signal intensity of the myometrium, the hyperintensity of the endometrium. The similar thing is appreciated here. You can very well appreciate the posterior lip of the cervix with a low signal intensity which has not been involved, a normal appearing low signal intensity of the vaginal mucosa, and this is the disease which has been delineated here. Parametrial invasion of the cervix, it is to understand this, it is important to understand that there is a low signal intensity cervical stromal ring which is there, and if this low signal intensity ring is preserved, then there is no parametrial invasion. As also in this case, the low signal intensity ring is preserved, there is no parametrial invasion, but you in this you can appreciate that on the left side there has been a loss of the cervical stromal ring and there is a frank parametrial invasion. In this case, as also in this case, rest of the ring is preserved, but there is a parametrial infiltration in this case, and there is a frank parametrial infiltration. So most of the times this infiltration loss of the stromal ring will implicate a parametrial involvement in a case of a cervical cancer. Vaginal involvement is difficult to delineate on MRI. However, if a proper vaginal jelly has been inserted, then it will very well highlight the inner hyperintensity of the jelly and a normal vaginal mucosa low signal intensity. As in both of these cases, you can see that a small disease and a relatively large disease, but there has been no vaginal involvement. However, in this case, there is an anterior vaginal involvement, there is a posterior vaginal involvement, and very important to remember that clinical examination is the best, even superior to MRI for vaginal extension of the disease. And use of vaginal jelly would improve your estimation during MRI. In this case, understanding the uterine body involvement, again, it would be difficult for a clinical examination and a CT scan to accurately identify the extent of uterine body involvement, where MRI far superior. There is no uterine invasion in this case. In this case, there has been an invasion of the uterine isthmus, and in this case, there has been an invasion of the uterine body in the upper part as well, sparing just a few centimeters maybe from the top of the uterine fundus. MRI would also help us delineate or understand the anterior bladder wall invasion or the posterior rectal invasion. However, it has to be corroborated with endoscopic findings along with a biopsy. Now coming to lymphatic drainage of the cervix. So there are three routes of lymphatic drainage. However, the most common is the route 1, where there is a systematic drainage of the lymph nodes from the parametrial to the iliac group of lymph nodes, to the pelvic group of lymph nodes, and then to the paraortic group of lymph nodes. The other routes were from through the ovarian suspensory ligament to the paraortic lymph node or along the round ligament to the inguinal lymph nodes are rare. The parametrial, obturator, iliac, sacral, presacral, and paraortic are considered to be regional lymph nodes for cervix, and inguinal lymph nodes, mediastinal lymph nodes, or supraclavicular lymph nodes are considered to be non-regional, and these are stage 4B. Most of these normal nodes would be subcentimetric, they would not be visualized by routine imaging. However, the important thing to understand is they lie adjacent to major blood vessels. And this important anatomical information will help us to delineate the lymph nodal regions electively when we are treating these patients. Important to understand is the bifurcation of abdominal aorta into common iliac right and left, and then further common iliac bifurcation into external iliac and internal iliac. Internal iliac further gives rise to branches, and of this, the anterior offshoot branch is the obturator artery, and this obturator artery travels down in between the external and the internal iliac artery branches and exits the pelvis through the obturator canal. So this information is important. So this is the external iliac artery. These are the smaller branches of the internal iliac artery which are exiting the pelvis, and the obturator would lie somewhere in between the internal and the external iliac artery. One important branch of external iliac artery, which is given at the level of inguinal ligament, which corresponds to the caudal most extent of the external iliac lymph nodes, is the inferior epigastric artery, or the deep circumflex artery. Of this, the inferior epigastric artery is very well visualized on a contrast enhanced CT scan, and this would serve as the caudal edge of your external iliac contour. Again, the external iliac group of lymph nodes, they have got three major groups. One is the lateral group, the anterior group, and the medial group. So it is very important to understand that this is the three major groups, and this has to be included by giving a larger margin electively while we are contouring the external iliac lymph nodes. The obturator artery that we understood, there is a branch from the internal iliac artery. This is the obturator artery in the pelvis just before exiting outside the pelvis through the obturator canal. So it is important to identify this obturator canal on the CT scan images, and this would serve as your caudal boundary for ending up of your uh, obturator lymph node elective contour. So this anatomy understanding is very important. It's also at the same time important to understand the distribution of the para-aortic lymph nodes. So it has been found that the left para-aortic, the aortocaval, are the more important areas where the lymph nodes are seen. This is a study from the PET-CT distribution of the lymph nodes. Because the majority of the lymph nodes either would lie in the left para-aortic or the paracaval area, and very few lymph nodes are seen in the right paracaval area. So when we are again electively delineating this information is important to give larger margins on this sides to cover all these electively involved lymph nodes. So the modality of choice for nodal metastasis, although CT and MRI have got good specificity, but PET-CT is much more sensitive. It can detect smaller lymph nodes. In this case, you can see the para-aortic lymph nodes has been detected by the PET-CT, so it is the preferred modality of choice. It is also important to understand the anatomy of normal versus pathological lymph nodes. The smaller lymph nodes with a short axis dimension of less than 10 millimeters are oval appearing in shape are characteristics of a normal lymph node. So this is a normal obturator lymph node seen in a case of cervical cancer, whereas a cluster, even though if it is smaller, clustered, irregular in shape, is a characteristic of a pathological lymph node. So when do we consider nodal involvement? If it is a PET positive disease, if the short axis dimension is more than 10 millimeters, even if it is 5 to 10 millimeters, but if there is increased intensity on T2 weighted images, decreased diffusion, irregular borders, lost architecture, round in shape or inhomogeneous, we will consider this as pathological lymph nodes. It is very important because distinguishing between a normal and pathological lymph node is very crucial to the delivery of radiation therapy doses and future failures. So the important take-home messages are we need to very carefully understand the normal and pathological anatomy of cervix and lymph node drainage areas, and this is very helpful for a successful planning of both external and brachytherapy. We should never forget a good clinical examination, which should be always done along with the imaging. In the contrast CT scan of the pelvis, we need to remember that the endometrium and the cervical stroma will take up a low signal intensity. Myometrium will show enhancement, and cervix cancer will show a iso-intense or low signal as compared to the normal cervix. In a MRI T2 weighted image of the pelvis, endometrium will show a high signal intensity, junctional zone low signal, myometrial intermediate signal, and the cervix cancer will show a high signal intensity, whereas the loss of normal low intensity cervical stromal ring implicates a parametrial involvement. And it is important to distinguish between normal and pathological lymph nodes and also understand the lymph nodal areas based on the vessel's anatomy, which would be helpful for us in future planning. So thank you very much for your kind attention. And if there are queries, you can email these queries to me. And I would like to acknowledge and thank Dr. Umesh Mansetti, Dr. Primoz Petrick, and all the faculties of the Aero Histogyney teaching group who have been helpful. So thank you very much.